Howdy, y'all. I'm Dr. Jeff Jarvis, and I want to talk about the acute coronary syndrome and STEMI protocol. Now, there are several key points I want to make up front, and then maybe give a little bit of minutia that you won't see all the time, but it could make a difference for patients if you pick them up the few times they do occur. So let's jump right in, shall we? Acute coronary syndromes, or ACS. That's a disease continuum that goes from stable angina to unstable angina to non-ST segment elevation myocardial infarction, or NSTEMI, to STEMI, ST segment elevation MI. There are also these things out there called OMIs, or occlusive myocardial infarction. Those are basically STEMIs that forgot to elevate their ST segment. Now, the basic pathophysiology of this entire continuum is the same, and it's important to understand it. All of these disease presentations, they're caused by a mismatch in the myocardial oxygen supply and demand. It's a supply and demand issue. Either the blood supply is compromised because of narrowed or completely occluded coronary arteries, or because demand exceeds supply, or some combination of the two. Now, heart attacks, NSTEMIs and STEMIs, they occur from supply problems. These are the clogged or occluded arteries. Those are called type 1 MIs, and they're the ones that benefit from going to the cath lab, or percutaneous coronary intervention, PCI. Now, type 2 MIs occur because of excessive demand on the heart. These are also called, not surprisingly, demand infarcts. These usually do not have ST elevation, and they do not benefit from rushing to the cath lab. Now, example of type 2 infarcts are the 45-year-old who's been doing a little math, or the 85-year-old with sustained atrial fibrillation with rapid ventricular response. Not to imply the 85-year-old is not doing math either, but I think you get the idea. So these patients need to have their heart rate lowered, not their arteries opened or their platelets killed off. They can damage their myocardium and leak cardiac biomarkers like, say, troponin, but they still don't benefit from PCI because the problem isn't the artery, it's the demand. Now, among patients with supply problems, the coronary artery supplying a section of the heart either becomes narrow because of, say, corn dogs,
called plaque. As a result, your artery is narrow.
That limits the amount of blood flow to that section of the heart, or they completely occlude, blocking blood flow. Angina is caused by gradual narrowing of the arteries, which causes symptoms, but not a heart attack. The arteries are narrowed, but there's still sufficient blood flow to avoid any ischemia at rest, but the limited supply is insufficient to meet the needs of the heart with exertion. Now, the result is chest discomfort. If demand decreases with rest, then the limited supply is again sufficient for the decreased demand, and symptoms alleviate. An MI, or heart attack, occurs when plaque ruptures along the endothelial lining of the artery, exposing the underlying lipids. That's where the corn dogs come in. This sets off a rapid cascade of events, starting with clot formation and leading to complete obstruction. Rest does not alleviate these symptoms because there just is not any blood flow. It's not just limited blood flow from narrowing, but no blood flow at all because of complete blockage. Now, this clot formation is called a thrombus, and that's not to be confused with an embolism or embolus. Now, an embolus is a clot that forms elsewhere and then goes downstream to cause an obstruction. Pulmonary embolism is the classic example of that. Now, what we're talking about here is a thrombus. It forms in location. That's where that plaque ruptures, the clots form, boom, occlusion. Now, the biology of clot formation can be used during treatment. For example, aspirin, something we give to patients with heart attacks, blocks production of something called thromboxane A2. That is important because it allows platelets to link together and form clots. When you give aspirin, it slows the growth of the clot. Aspirin, as it turns out, we can quantify this, it can prevent death in 1 out of every 42 patients who get aspirin when they're experiencing an MI. That's why it's important to give it sometime during the duration of our contact with these patients. Now, the other medication we give for MIs, nitroglycerin, can help relieve symptoms by dilating coronary arteries and increasing blood flow, allowing it to match the demand. Now, all presentations across the ACS spectrum can present with a variety of symptoms, so it's important to keep your mind open to the possibility that the patient may have ACS, even if they're saying, well, I don't have chest pain. This is where it's important to understand why we're asking questions during our history. We're forming a differential diagnosis. That's a list of the potential diagnoses that might be causing the patient's symptoms. And then we're asking clarifying questions to help structure, order that list, that differential, so that we can get them sorted in terms of both acuity and likelihood of occurrence. Now, while a 12-lead ECG is a diagnostic characteristic of STEMI, it is not enough by itself to make the diagnosis. We have to combine the findings from the history with the findings from the ECG to make a diagnosis. Now, when I have analyzed the patients that we call a STEMI who are not actually having a STEMI, what I found is that we are focused on the ECG to the exclusion of the patient. You can't have a STEMI with no symptoms, and you can't have a STEMI with no ECG findings. You have to have the two together.
It takes two, baby. It takes two, baby, to make a dream come true.
That's why the history is so important. Now, speaking of history and what patients complain of, some patients clearly have STEMIs and don't have chest pain. Now, particularly the groups that we think about here are women and diabetics. But despite that, it's important to know that even in these patients, some type of chest discomfort, even if they don't say it's pain, some type of chest symptom is still the most common symptom when having a STEMI. So speaking of that discomfort, patients frequently perceive and describe their symptoms differently, so we need to listen carefully to them and hear what they're saying about their symptoms. They may describe the symptoms as a heaviness, a squeezing, or maybe a pressure in their chest and not call it a pain at all. Consider those symptoms synonymous with chest pain. Now, classic chest discomfort caused by ischemia is brought on with exertion. It's often described as a heaviness, squeezing, or a tightness, and it may radiate either to the jaw or the shoulder and either the right or left side. Pain radiating through to the back, or maybe it starts in the chest and radiates down into the abdomen, particularly when it's described as a ripping or tearing sensation.
Rip and tear until it is done.
That needs to make us think of aortic dissection. Ischemic chest symptoms may get better with rest or nitroglycerin when they are caused by angina. This is more likely when symptoms are similar to the patient's prior anginal symptoms. It's important to know, however, that nitroglycerin may not relieve symptoms from an MI, and they may relieve symptoms from non-cardiac causes like, say, esophageal spasms. And because of this, we really should not base our diagnosis on symptom response from nitroglycerin or a lack of response from nitroglycerin. Ischemic symptoms typically last for 20 minutes to a few hours if they get better at all. Symptoms described as jolts, pinpricks, or those that last only a second or so at a time, those are rarely cardiac. Likewise, pain from a cardiac cause rarely lasts days at a time. When asking a patient how long the symptoms have been going on, it's important to ask some follow-up questions to make sure you understand what they're saying. For example, a patient may say their discomfort has been going on for days, leading us to think that's less likely to be cardiac. But if you ask further, hey, have you been having these symptoms continuously for days? Or are there multiple episodes of the same pain? You might find out that what they're really having is 5 episodes, say, of the same discomfort. Each one occurs with exertion and is relieved by rest and lasts about 30 minutes at a time. And you've had about 5 over the last few days. That's an entirely different picture, and it's much more likely cardiac than non-stop continuous symptoms. Now, associated symptoms like nausea, vomiting, diaphoresis, or dyspnea may also be present. Some patients may have only these associated symptoms. That's the atypical presentation. Remember, though, that even among patients most at risk for atypical MI, those women and diabetics, chest discomfort is still the most common symptom. One more time, to diagnose a STEMI, we need to have both an appropriate clinical situation and diagnostic EKG findings. I repeat it because some things are worth repeating. This means that if the 12-lead ECG reads STEMI, or if you're interpreting it as a STEMI, but the patient is complaining only of left toe pain from, I don't know, dropping a bowling ball on his foot after he's had a couple too many beers.
Really screwed up.
That is highly, highly, highly unlikely to be from a coronary artery occlusion. Much more likely he needs, say, to sober up and have some Tylenol rather than PCI.
Hey, bud, you okay?
No, not okay.
You look good, you got some color, I'm jealous.
I'm getting married today.
We don't call those. Now, on the other hand, the same ECG in a patient with a sudden onset of crushing substernal chest discomfort that's radiating to the right jaw and associated with nausea and diaphoresis that started with exertion, that is almost always a STEMI. Call those. So, one more time, a STEMI is the combination of both appropriate clinical context and the ECG, but not either one of them by themselves. With that bit of pathophysiology and history taking out of the way, let's cover the protocol. At the basic level, the key components are assessment with a good history and rapidly obtaining a 12-lead ECG when you have the box available. Now, I really want to make something clear here. I don't think there is any such thing as a basic or an advanced history. I think that's a meaningless distinction. Talking to patients, it's a mandatory part of every clinician's scope of practice. Taking a good history is the most important skill any clinician can have, and it isn't limited to a certain credential level. This doesn't mean, of course, that we should have in-depth discussions about, the patient's feelings for their 3rd grade teacher, just as an example, no matter how much they might want to tell us all about it. It's not what it means. And it certainly doesn't mean that we should delay obtaining a 12-lead, but we are all bright people here and we can walk and chew gum. We can get a good history in a polite and compassionate fashion and still deliver prompt care. By the way, it turns out that talking to patients in a compassionate way is the single best patient satisfier out there. As the saying goes, people don't care how much we know until they know how much we care. Let them know you care. Listening to them and talking to them is one of the best ways to do this. So, back to the basic protocol. If you suspect ACS, give aspirin unless there is a reason not to. Say the patient says they have an allergy to it, or they just flat refuse to take it. If they've already taken an aspirin, feel free to give them another. When it comes to ACS, let's just say we don't like platelets. It's okay to hurt a couple more of them. It's just going to stop that clot progression a little bit better.
Dead or alive, you are coming with me.
Now, administration of aspirin is one of our core performance measures, so be sure to document that you gave it. If there's a reason for not giving it, document that too. Now, the way to do that is to document administration of aspirin and then select the little box in ImageTrend with the negative symbol on it. That allows you to suggest or select why you didn't give it. This allows you to honestly document that you didn't give the aspirin, but it also allows you to say why it wasn't given, and you get credit for considering and attempting to give it. I know it's an odd little button in there, but it does make a big difference in our ability to demonstrate the great work that y'all do. So here's another reminder. Obtaining a 12-lead ECG is not only a basic skill in this system, it is an expectation. It is not acceptable to have a $20,000 monitor on your unit and not use it to help your patient, even if another unit is, quote, right around the corner. The faster we obtain that 12-lead ECG in patients who are having a STEMI, the faster we can notify the hospital and the faster they can get ready to open up that artery. Now, as much as I hate cliches, this one's true. In MIs, time really is muscle. The faster we can get the artery open, the better off we'll be. Now, if you're not the transport unit, hand the ECG to the incoming transport medic and point out the interpretation. If you are the incoming unit and you're handed a 12-lead that says STEMI, or otherwise meets appropriate STEMI criteria with the appropriate symptoms, of course, then don't take the time to repeat the 12-lead. You already have your answer. Go ahead and notify the hospital and then document the time that you did it. Also, document the time that first 12-lead was obtained. Not the time you read it, but the time it was obtained. This allows us to accurately measure two other key performance measures for STEMI pain: time to first 12-lead ECG and the time to call a STEMI alert. These measures are tracked by the American Heart Association as part of Mission Lifeline, and they are important to patients. Now, when we're talking about measures, it's important to understand which patients we measure these in. For these three measures, we're only measuring them in the patients we diagnose with STEMI, as indicated by the primary impression. Our performance goals here are to give all patients with STEMI aspirin before we get to the hospital, so sometime during our care. We need to obtain that first 12-lead ECG within 10 minutes of making patient contact, and that is why it is so important that our first responders get that. Don't wait for the ambulance. And then the last is calling a STEMI alert to the hospital within 10 minutes of the first diagnostic 12-lead. So let me give you a scenario. You are worried about a patient, you get a 12-lead, but it's not diagnostic. But you're suspicious because they have a good story. So you get serial 12 leads, you get another one and another one. And if a subsequent 12 lead is diagnostic, then you call the alert. Just be sure to document the times accurately and whether you interpreted the ECG, each ECG, as a STEMI or not, because that allows us to accurately calculate the time to the STEMI alert. Basing it off of that first ECG, if the first ECG was not positive, that's not fair. We want to help you, but help us help you. Document each 12 lead and when you interpreted it as diagnostic for STEMI. So the other thing we want to do is, if you think the patient is having a STEMI, go ahead and place multifunction pads on so that if the patient goes into VTAC or VFib, we can rapidly act with the ZAP button. That improves survival. Now, it probably goes without saying, but STEMI patients should go to the closest STEMI center listed in the hospital capabilities list. Okay, now for some of those finer points of assessment and diagnosis. So we've historically been taught, and Lord knows that I've taught this too, patients with right ventricular infarct should not receive nitroglycerin. Why? Well, it's because of a concern that the right coronary artery perfuses the right ventricle, and an MI that is affecting the right ventricle may lead to decreased stroke volume out of that right ventricle and therefore decreased preload to the left ventricle, and that can make these patients hypotensive or be at risk for becoming hypotensive. Now, since nitro decreases preload, and the problem with these patients who are hypotensive is that they don't have enough preload, the nitro could make it work, and therefore we shouldn't give it at patients at risk. That's a great concept. I love this concept. This is why I taught it. But like a whole lot of great concepts, sometimes it does not hold up to strict scrutiny. Recent papers, as a matter of fact, have looked at this, and they've demonstrated that in patients who are not hypotensive, even those with a documented right ventricular infarct, nitroglycerin is safe and doesn't lead to any more hypotension than any other patient. So because of this, confirming that the patient is having a right ventricular infarct isn't as important as we thought it was. They're still going to go to the cath lab. But for purely academic reasons, just if you want to know, let's talk a little bit more about it. We ought to consider an RVI in patients with an inferior ST elevation, because in most patients, the inferior wall of the left ventricle is perfused by the right coronary artery. The RCA also perfuses the right ventricle. Now, leads 2, 3, and AVF are looking at the inferior wall of the left ventricle. Don't be fooled and think that those leads are looking at the right ventricle. They're not. Here's a trick for you. If you ask yourself which leads on a normal 12 lead look at the right ventricle, this is a great question for our new paramedics, by the way. The answer is none of them.
Got him!
Nothing looks directly at the right ventricle. We're looking at the inferior wall of the left ventricle. So if we see elevation in those inferior leads, again, that's 2, 3, and AVF, assume that the RCA is the culprit lesion. And then if you really want to know whether there is right ventricular involvement, you have to look directly at the right ventricle. And because there are no leads looking at it, you got to make one. Take V4 off from the left side and move it over to the right side. Right where V4 was on the left, make a new V4 on the right and call that V4R. If you see elevation there, that's your RVI. But assuming they're not hypotensive, you can still give them nitro. Now remember, the computer does not know that you moved V4, so you have to mark V4R on the printout, circle it in your pen and say V4R. And then when you're documenting it, document that in the procedure. All right, now some more style points. Patients can have a complete coronary occlusion but not have ST elevation, and they can still benefit from PCI. These are those OMI patients I mentioned earlier. Now, why is it they've completely occluded their artery, they're infarcting up and down throughout the myocardium, and they still don't have ST elevation? Honestly, I have no idea. Beats me. Hearts are just rude that way. Maybe it's just the heart's way of keeping us humble.
When you bully the wrong person and get humbled badly.
Probably something that's good. Arrogance in all of us doesn't help us be good clinicians. Either way, whatever the reason is, these patients can still benefit from PCI just like STEMIs. So the hip new term for this condition, it's essentially a STEMI, but without elevation. And yes, I know that's an oxymoron, but like I said, the heart doesn't care if, I don't know, your ox is moronic. STEMI, no elevation, OMI. There are a couple of ECG patterns to be aware of that can help us identify these. Now, I really don't want to jump into the weeds of 12-lead interpretation here, specifically about OMIs, because honestly, I kind of think sometimes it's about as close to trying to divine the inner meaning of the heart's deep feelings, sort of like throwing blood and chicken bones into a plate and seeing what they're I don't know what it is. Don't do it. So I don't want to get too far in the weeds here, but to give you some things, we just included a couple of pictures in the protocol. Take a look at that. We may do a deep dive on this later on in a future video, but for now, if you're interested in it, just know it exists. Take a look at a couple of resources on the web. Dr. Stephen Smith's ECG blog on the web. is really good. Take a look at it. He really gets into the weeds on the OMI stuff. If you like it, go for it. I don't want to stress it here because sometimes I think it gets us to missing the forest for the trees. But if you're an ECG nerd, well, hell, if you're an ECG nerd, you probably already know who Dr. Stephen Smith is. So that's pretty much the ACS protocol. The key things I want y'all to know are the pathophysiology of ACS, what to do about it, how to accurately document it, so we can demonstrate the care that y'all give. Y'all do outstanding work. I want everybody to know about it. So to summarize the what to do about it part of the protocol, here we go. Basics should get a good history, obtain a 12 lead, give aspirin and nitro as appropriate. Paramedics should go ahead and notify the hospital as soon as a STEMI is identified. 3 performance measures around STEMI care. Give aspirin or document why you didn't. Obtain that first 12 lead within 10 minutes of patient contact and activate and document a STEMI alert to the hospital within 10 minutes of the first diagnostic 12 lead. All right, that's it. There's your summary. Thanks for watching. And guys, seriously, thank you for what y'all do every single day to care for our community. Take care, y'all.